Hi, sorry we're starting a little bit late. We just got done with some votes on the floor. I don't think we got done with them yet, but we're assuming that they will finish up one way or the other in the other half hour, and they're going to finish up without me and without Mr. Sessions. Okay, today we have a roundtable on the Subcommittee on Healthcare and Financial Services. We're discussing shocking rampant fraud in the government one more time, this time fraud involving skin substitutes in wound care. Around 2 weeks ago, I was at a press conference with the White House Task Force to Eliminate Fraud, led by Vice President Vance. At the press conference, Vice President Vance detailed the shocking and troubling 7,100% spike in Medicare claims for skin substitute procedures over the past few years. They have neatly prepared a graph to see that something was obviously wrong. Here we have in 2019, 7 short years ago, 7 short years ago, we have $0.2 billion spent on Medicare claims for allografts. Last year, we were at $14.4 billion. So you would say, obviously something is wrong and demands a hearing, and obviously the taxpayer or representatives of the taxpayer should be paying attention. Skin substitutes are biosynthetic or tissue-derived wound coverings applied to treat severe burns, surgical defects, and chronic wounds. Some of our nation's most vulnerable patients rely on these products. It is no accident, therefore, that these patients are often among the most susceptible to those who wish to profit off them. Skin substitute fraud is highly concentrated in assisted living facilities, skilled nursing facilities. Recent investigations by the Department of Justice, the Department of Health and Human Services, Office of Inspector General, and the Centers for Medicare and Medicaid Services have revealed alarming patterns of fraud, waste, and abuse. Not surprising, looking at the numbers. In some cases, providers billed Medicare for medically unnecessary skin substitute procedures, repeatedly applying products with no or little documented clinical benefit. In other cases, the providers submitted claims for services that were never even provided. The growth in Medicare payments on skin substitutes has been staggering. Again, between 2019 and 2025, a 6-year gap, spending increased from $200 million to $14.4 billion. That is an increase of about 75 times in just 6 years. This raised serious questions about whether existing reimbursement policies created incentives that bad actors were able to exploit. While the overwhelming majority of healthcare providers seek to serve patients ethically and responsibly, the mass fraud we've witnessed in skin substitute market demonstrates how the loopholes in payment systems can attract those looking to profit at the expense of taxpayers and beneficiaries. And quite frankly, it doesn't say much about this line of health care provider. Fortunately, the Trump administration has put a stop to the excessive billing. CMS has implemented significant reimbursement reforms aimed at eliminating incentives that contributed to excess spending, while the Department of Justice has pursued enforcement actions against individuals and entities alleged to have engaged in this fraudulent conduct. These efforts are important not only for protecting taxpayer dollars, but also for preserving access to legitimate and clinically appropriate wound care treatments. That is the purpose of today's roundtable. We want to better understand how these fraud schemes operate, why Medicare became vulnerable to such dramatic spending growth, and whether recent reforms are sufficient, and what additional steps Congress and federal agencies should take to protect patients while ensuring responsible providers and manufacturers can continue to deliver innovative care. I appreciate our participants being here. We have 4 wonderful witnesses today. We look forward to them sharing their expertise and we look forward to a thoughtful and provocative discussion. We will notice that my good ranking member, Mr. Krishnamurthy, is not here, so he will miss out on an absolute incredible story that everybody in this country should be aware of. Now, we're going to introduce today's roundtable participants. First, Mara McDermott, Chief Executive Officer, Accountable for Health. Secondly, Amir Almajar, Chief Medical Officer and co-founder of Vitalize Health. We are also joined by Mr. Joseph Caper, Chief Executive Officer of MyMedics Group. And finally, Ms. Yelena Olmsted, Chief Executive Officer of Lavaris Global. I will turn this over to my guests for any opening remarks. Usually we have a time limit of 5 minutes. Due to the situation we have here today that some people aren't showing up, you can go 7 minutes. How about that? Okay, and we'll go right across from, from your right to left. So we'll start Ms. McDermott.
Great. Thank you, Mr. Chairman and member of the committee, for having us today. I am really grateful for the opportunity to share our feedback. My name is Mara McDermott. I'm the Chief Executive Officer of Accountable for Health. We're a national, nonpartisan advocacy and education organization committed to the adoption of effective, accountable care. I appreciate the committee's attention to what has become one of the most significant examples of fraud and patient harm in the Medicare program. And today I want to share 3 key concepts with you. First, as you mentioned in your opening, skin substitute spending has exploded. There's no other way to describe it. In 2019, Medicare paid $250 million for skin substitutes. By our math, actually a little higher than your math, $19 billion in 2025, probably a difference in categories of products included. And then, as you mentioned, an over 70-fold increase in just 6 years. Underlying that math is a flawed payment mechanism. Medicare pays for these products by the square centimeter. While some products are reimbursed under $11 per square centimeter, in 2025, high-cost products were reimbursed nearly $5,000 per square centimeter, and recently some even coming in higher than that. Skin substitutes provided perhaps the most extreme example of flaws in a fee-for-service payment system. Fortunately, last year, the administration took decisive action to cap the price of skin substitutes at $127 per square centimeter, a change Accountable for Health and its members strongly support. The Congressional Budget Office estimates that this payment change saves over $250 billion over the 10-year budget window, $250 billion. Second, unfortunately, all of us in this room are familiar with runaway Medicare spending. We've seen it before. The case of skin substitutes is unique because of the extreme patient harm that has flowed as a result of overuse and inappropriate use of these products. I want to share 2 patient stories with you today, although we have many more at our website, woundcarenightmare.com, if you want to check them out. A patient we will call Maria was an 88-year-old woman living with dementia in San Antonio, Texas. After suffering a stroke, she became homebound and developed pressure wounds on her lower back and hips. Maria received 12 skin substitute applications generating more than $10 million in Medicare claims over about 45 days. Over 7.5 square feet of skin substitutes were applied to her body. During this time, she received no lab work, no primary care, no follow-up visits, and no rehabilitative services. The only services provided were continued repetitive wound care procedures. Unfortunately, she died about 2 months after the skin substitutes treatments began. A second patient that we're going to call Barry, and I think had a fairly common experience, switched from a Medicare Advantage plan to traditional Medicare because his Medicare Advantage plan would not approve skin substitutes for his condition. The plan did not think it was clinically necessary. In traditional Medicare, Barry's wounds were handed off to a wound care provider who performed 12 surgical procedures, racking up over $3.5 million in claims. None of the usual safeguards were followed, no infection control, no physician oversight. Barry's wounds became so neglected, they were eventually infested with maggots. His lower leg was amputated after he was hospitalized for sepsis. Unfortunately, these stories were becoming all too common. We were hearing calls from our membership on a near daily basis before the payment change. Again, we are so grateful to the administration for stepping in to stop this crisis and to take actions to bring bad actors to justice. Third, we would like Congress to continue to recognize the essential role of accountable care organizations in bringing fraud and abuse to light, in advocating for payment changes, and ultimately in helping to bring bad actors to justice. Because accountable care organizations are responsible for total cost of care for their patients and for quality, they often detect unusual utilization patterns long before fraud detection systems in Medicare can. Our members recognize these trends early. You're going to hear from one of our member companies about that in just a moment. They investigated suspicious billing, they educated their physicians on evidence-based wound care, developed alternative wound care management programs, reported suspected fraud to the authorities, and worked with CMS to identify practical policy solutions. In other words, accountable care organizations acted as Medicare's early warning system. They can serve as trusted partners in identifying fraud and making sure that it does not become the next national crisis. We have an opportunity to learn from what happened here and build a Medicare program that is more accountable, transparent, and more focused on delivering high-quality care to the patients that it serves. Thank you for the opportunity today. I really look forward to the rest of the conversation and to answering your questions.
Thank you. Doctor?
Thank you. Mr. Chairman and members of the subcommittee, thank you for the invitation today to join today's roundtable. I'm an internal medicine physician and co-founder and chief medical officer of Vitalize Health, an operator of accountable care organization, or ACOs. Focused on independent primary care, Vitalize operates in 30 states, partnering with primary care physicians on improving patient care while reducing costs. Since entering Medicare's ACO programs in 2019, we've expanded our impact, and in 2026 alone are on track to save Medicare more than $250 million. One of the things we do is identify potential fraud in as close to real time as possible using a combination of CMS-provided claims data and input from our physicians and patients. We've experienced firsthand the damage that abusive spending can cause to our providers, patients, and taxpayers, and we work alongside CMS to address it. I want to start with some good news. Physician-led accountable care organizations, including Vitalize, have consistently generated savings for the Medicare program while improving quality of care, because our organizations have an incentive to ensure patients receive better care that keeps them healthy and out of the hospital. We proactively get patients to see their primary care providers, deliver actionable clinical recommendations at the point of care, and follow up with supportive interventions at home. Research shows that our approach reduces hospitalizations and can lower mortality rates by up to 45%. Bottom line, ACOs are accountable for the cost and quality of a patient's care, which improves patient outcomes while reducing costs. ACOs also have an obligation and an incentive to report potential fraud. On today's topic, traditional Part B spending on skin subs, as we've discussed, went from $250 million in 2019 to more than $14.4 to $19 billion in 2025. At Vitalize, when this was happening live, we actually identified 2 hospice patients in 24 who were generating more than 2.1 in skin substitute spending within months prior to their death. Trends continued to worsen in 25, with 11 of our patients having skin sub spend of more than $1 million each. We actually had 1 patient with $36 million in skin sub billing between April and September of that year. These cases were reported to CMS, but ACOs do not have the power to intervene and stop the payments. When Medicare pays an inappropriate claim for one of our beneficiaries, that money comes out of the taxpayer's pocket and takes advantage of vulnerable patients. ACOs only succeed when patients get better quality care and taxpayers save money. Again, ACOs are uniquely positioned to identify and report potential fraud to the government because we have both the comprehensive claims data and, most importantly, strong relationships with our providers and patients, which we leverage to identify when a problem arises. To be clear, skin substitutes are not inherently the problem. Vitalize and others in the ACO community previously identified problems in urinary catheter billing, where Medicare payments grew 14-fold in 2 years. When such patterns arise, ACOs raise the alarm early. However, after reporting suspicious billings, payments typically keep flowing. You know, the Office of Inspector General has recognized the role that ACOs can play. The OIG recommended that CMS prioritize ACO referrals for potential fraud, and CMS agreed. In January, CMS took an important step by establishing a dedicated fraud referral channel for ACOs. We applaud this progress and look forward to partnering with CMS to further leverage ACO's unique ability to identify and combat fraud, waste, and abuse. We've actually proposed a targeted solution that would allow qualified ACOs with proven capabilities to trigger immediate prepayment review of suspected fraudulent claims. Unlike prior authorization, this proposal would not delay treatment. It would simply pause payment while Medicare's existing claims contractors conduct a review. By converting an ACO's fraud referral from a tip that may sit for months into an immediate payment hold, Medicare could stop fraudulent payments earlier. We've had discussions with a number of offices on this idea and hope to continue to build momentum. The recent spike in urinary catheter spend, at the same time skin substitute spend was reaching record levels, makes clear that suspicious billing is not limited to one product or service. Bad actors will simply move to the next opportunity. You know, CMS has already taken important steps to strengthen the program integrity, and we appreciate its leadership in this fight. ACOs can build on that work because we have, once again, the data, relationships, and incentives to spot these schemes early. If qualified ACOs can trigger a timely review, we can stop improper payments before taxpayer dollars leave CMS rather than trying to recover them months or years later. Vitalize and the broader ACO community stand ready to work with Congress and CMS to protect Medicare patients and taxpayers. You know, I want to personally thank the committee for your attention to this very important issue, and I look forward to your questions.
Thank you, Mr.
Mr.
Chairman,
Capper,
for the invitation to address this roundtable on issues regarding Medicare reimbursement for skin substitutes. My name is Joe Capper, and I'm the Chief Executive Officer for MiMedx, a NASDAQ-traded medical technology company. I have over 30 years of experience in the medtech industry, having led 3 public and 1 private company. MiMedx is a pioneer and leading provider of healing solutions in wound care, surgical, and surgical recovery settings. As one of the original few companies that developed the market for placental allografts in the wound care space, MiMedx has driven the advancement of scientific research, clinical evidence, and cost-effective outcomes for these products. In 2020, the Agency for Healthcare Research and Quality recognized our contributions when it published a report covering skin substitutes for treating chronic wounds, which noted that nearly half of the well-designed studies of placental allografts with low risk of bias were studies on MiMedx products. It is with this backdrop that I respectfully offer my thoughts to the committee on Medicare reimbursement for these products. Let me begin with the overarching comment that we applaud the Centers for Medicare and Medicaid Services for taking action and revising the payment structure in both the outpatient prospective payment schedule and the physician fee schedule for calendar year 2026. This was a significant first step. Over the last several years, MiMedx has been a lonely but loud voice warning against the abuses and wasteful practices in this product category and advocating for significant reform, including many structural changes that were incorporated into the 2026 final rules. Stated plainly, the ASP plus 6 methodology was never the appropriate reimbursement structure, as products in this category are neither drugs nor biologics. Coupling the ASP methodology with the low barrier regulatory pathway under Section 361 of the PHS Act created an environment that enabled participants in the industry to use these critically important products as a means for enormous financial gains, driven by rampant fraud, waste, and abuse. We saw the average price per square centimeter for skin substitutes rise from $150 to $200 to some products costing almost $5,000 in only a few short years. And these were for products that had no clinical evidence to prove their safety and efficacy. Companies such as MiMedx, who have conducted clinical trials for their products and know they work, found it increasingly difficult to compete due to the many unscrupulous actors entering the category. Notwithstanding our overall support for the steps CMS took in the 2026 final rules, which resulted in a significant reduction in costs to the Medicare Trust Fund, we do have a few suggestions that we believe will further address the waste and abuse that has characterized behavior in this space, while ensuring access and protecting all honest stakeholders, including healthcare professionals, product providers, CMS as the payer, and most importantly, Medicare beneficiaries. It is critically important to get the payment methodology right for the sake of the patients who suffer from complex, hard-to-heal wounds. We recommend 3 changes that we believe, if implemented together, will allow CMS to further limit fraud in this space and ensure beneficiary access to quality products. Number 1, increase the application fee for private office and home-based wound care providers. Number 2, reimburse skin substitutes at invoice price with a ceiling. Number 3, require evidence of product safety and efficacy. Let me elaborate on these points. First, regarding the application fee, we recommend CMS raise the application fee for the administration of skin substitutes in the private office and in home-based wound care settings to close the gap in the payment in these sites of service versus what is paid to clinicians in the HOPD care setting as set forth in the proposed OPPS. Clinicians should be compensated fairly for the work they perform. Instead, we have seen the perverse economic incentives for skin substitutes serve as a significant means of compensating clinicians, leading to the explosion in Medicare reimbursement in this category. We do not believe that product selection should determine whether or not a clinician profits from treating a patient. On our second point, we recommend that the price per square centimeter for skin substitutes be a ceiling amount. Stated a bit differently, we recommend that CMS reimburse skin substitutes at the actual price paid by the provider up to a cap, currently set at $127.14 per square centimeter. We strongly believe that CMS should reimburse skin substitutes at the actual price paid by the provider up to a ceiling versus reimbursing a flat rate notwithstanding what was actually paid. One of the hallmarks of the fraud, waste, and abuse related to skin substitutes over the last several years has involved product providers, manufacturers, and distributors deeply discounting the prices of these products, often in excess of 50 to 60%. This behavior allowed clinicians to capture the large spread between the amount reimbursed under Medicare regulations and the price actually paid for the skin substitutes. In fact, certain manufacturers and independent sales agents were actively advertising the profit a clinician could make using certain products, even without collecting the customary 20% copay obligation borne by Medicare beneficiaries. This created a wildly perverse economic incentive wherein clinicians focused on economic benefits to them as the reason to apply certain products over others for their Medicare fee-for-service patient population. This conduct is increasingly coming to light with the recent DOJ and OIG announcements. However, this behavior has not been eliminated by the lower price CMS set in the 2026 final rule. In fact, we are now aware that lower priced products with no proven clinical efficacy are being manufactured in other countries, such as India, and being sold to product distributors for as low as $8 a square centimeter, incentivizing some clinicians to still choose products based on the amount of profit they can realize rather than the proven efficacy of the product. Reimbursing based on the actual amount paid by the provider to the supplier up to a ceiling should have the effect of removing the practice of discounting from the market. Skin substitutes will effectively become pass-through expenses. Under this scenario, providers then need to be adequately compensated through a higher application fee. As the data from the last several years demonstrates, when product providers controlling pricing and discounting and clinicians make money based on the products they use, decisions are all too often based on the clinician's pecuniary interests versus what should drive clinical choice, namely safety and efficacy. Clinicians should be compensated fairly for the work they perform on behalf of their patients, not paid on the margin of the products they select. And last, we feel strongly that there should be a basic requirement for evidence to prove product safety and efficacy. This is the only category of products I am aware of for which CMS does not require evidence that the product works before Medicare will reimburse a physician for its use. CMS should require some basic level of evidence proving that the product does what it's supposed to do. It would also make far more sense to treat these products like devices rather than drugs and require them to receive an FDA 510(k) approval prior to entering the market. Incidentally, the source material to make a skin substitute product is derived from any other animal other than a human, it requires a 510(k) clearance. Another consideration I would like to touch on is the price per square centimeter. The current price of $127.14 per square centimeter is lower than industry expectations, and MiMedx has ideas on how to best set a price ceiling for these products. That said, this forum is probably not the best place to get into the weeds of the calculation, but I would be happy to sit down with appropriate people or CMS staff to walk through those suggestions at another time. Thank you for your attention, and I'm happy to address any questions the committee may have.
Thank you. Ms. Olmsted?
Good afternoon. My name is Jelena Olmsted, and I would first like to express my appreciation and gratitude to the chairman, the ranking member, members of the committee, my colleagues joining me in this discussion, as well as everyone who has taken the time to watch or listen to these proceedings. It is really an honor to be here. I have worked in healthcare for more than 20 years. Even though I'm not a physician, over the course of my career, I have had the privilege of seeing wound care from nearly every perspective, from patient's bedside to a product being developed, manufactured, commercialized, and sales associated with that product. I have assisted diabetics with foot ulcers who were unable to walk. I have worked with patients who needed specialized seating and positioning to prevent pressure injuries. I have helped individuals with ALS and their families navigate an unforgiving disease while trying to preserve the dignity and quality of their lives. I have seen the complexities of treating wounds in nursing homes, hospitals, and patients' own homes. My experience has included therapeutic support surfaces, negative pressure wound therapy, advanced wound care products, and skin substitutes. Whether the wound resulted from diabetes, an accident, vascular disease, immobility, an elderly patient's pressure injury, or a devastating condition such as an ALS, I have seen the positive outcomes that can result when wounds are treated early, and I have also, unfortunately, witnessed the negative outcomes that can happen when they're not. At every stage of my career, one principle that has guided me is patient integrity, safety, and outcomes must always remain at the forefront of every decision made. One of the main reasons we are here today is because fraud perpetrated by a series of bad actors in a devastating way impacted a sector of the wound care industry that was actually improving patient outcomes. Fraud must never be tolerated. Providers who knowingly perform medically unnecessary procedures, manufacturers that inappropriately manipulate the systems, and individuals who steal from Medicare should be investigated and held accountable. But enforcement must be precise. And unfortunately, the growth in the use of skin substitutes has been called fraud, when in fact, there are many providers who, given the authority the CMS has given them, are reaching an underserved population, usually in the rural areas, that previously did not have access to treatments, but now they do. Let me go further into these details. Prior to 2020, CMS rules required the skin substitutes only be covered when provided in the doctor's office. Of course, this proved to be a showstopper for many patients, such as diabetics with foot ulcers who could not walk and could not get to the doctor's offices in many instances. Then once COVID hit and CMS appropriately found ways to move care out of the doctor's offices and into the home. One of the changes allowed wound care providers to treat patients in their homes, which suddenly expanded access to a huge number of Medicare beneficiaries. This was a game changer for many who no longer faced the likelihood of amputation or death and instead could receive treatment. After COVID ended, CMS continued to allow home treatments, and across the country, providers continued to treat patients. This was an important step in the wound care treatment, and I call it out today because we need to be sure that Medicare policies allow for this care to continue. But although justifiable in the name of fraud prevention, the current policy may have taken a sledgehammer to a scalpel issue. Fraud is not unique to healthcare. The Government Accountability Office estimates that fraud across federal programs costs taxpayers between $233 billion and $521 billion annually. Pandemic unemployment fraud alone was estimated at between $100 and $135 billion, while the Small Business Administration Inspector General estimated that more than $200 billion in potentially fraudulent pandemic EIDL and PPP funds were being dispersed. I applaud Chairman Sessions for his leadership on his oversight committee in addressing fraud and being a good steward of taxpayer dollars in other areas of government. The government did not respond to fraud in these programs by concluding that every unemployed worker, every small business owner, lender, or public servant was acting inappropriately. Rather, the government identified vulnerabilities, pursued specific offenders, and worked to improve oversight. Wound care deserves the same disciplined approach. Today, the conduct of limited group of bad actors is creating a broad presumption of wrongdoing across an entire field. That presumption is having real consequences. Ethical physicians increasingly feel that practicing appropriate medicine may expose them to an unjustified audit, investigation, repayment demand, or accusation of fraud. Some are reducing services or leaving home-based and nursing home facility wound care altogether. When responsible doctors become afraid to treat, the patient pays the price. The patients most effective are often elderly, medically fragile, diabetic, immobile, homebound, or living in nursing facilities. They cannot always travel to a hospital wound care clinic weekly. Without physicians willing and able to reach them, wounds may deteriorate until a manageable condition becomes an infection, an emergency room visit, hospitalization, or an amputation. That is not merely a clinical tragedy, it shifts costs elsewhere throughout the entire healthcare system. A patient who could have been treated at home or a nursing facility may instead require ambulance transportation, emergency evaluation, intravenous antibiotics, surgery, inpatient nursing, rehabilitation, prosthetic care, and long-term assistance. Hospitals that are already facing staffing and capacity pressures will be asked to absorb more preventable wound care complications. We must examine the total cost of care, not simply the cost of one product associated with a single treatment claim. We must also remember what successful wound care accomplishes. Quality practitioners who use advanced therapies responsibly can and do change the course of patients' lives. And I can tell you this, these products do work. The effectiveness of skin substitutes is not just anecdotal, it has been proven over and over again by a growing body of clinical evidence. Closing a wound can mean avoiding infection or amputation, but its value goes far beyond closure. It can allow a patient to walk again, return to work, sleep without constant pain, remain at home, attend a grandchild's graduation, or simply spend more meaningful time with family. These outcomes do not always appear in our narrow reimbursement calculations, but they matter profoundly. Restricted access also threatens American jobs and innovation. Domestic skin substitute manufacturing supports tissue donation coordinator, laboratory technicians, clean room operators, microbiologists, quality and regulatory professionals, biomedical engineers, clinical researchers, warehouse workers, medical couriers, packaging suppliers, sales representative, nurses, and physician educators. Smaller American companies commonly reinvest revenue into cleaner manufacturing facilities, stronger quality systems, new clinical studies, improved products, and skilled domestic employment. If responsible manufacturers lose the ability to operate, we will not only lose jobs, we will lose competition, innovation, specialized knowledge, and domestic manufacturing capacity that may be extremely difficult to rebuild, as many will likely return to overseas opportunities. Congress does not need to choose between stopping fraud and protecting patients. It can do both. I recommend the use of claims analytics to identify extreme billing and utilization outliers. Above-board manufacturers are willing to collaborate with applicable government branches to formulate sound strategies and best practices that help mitigate and alleviate fraud. CMS should continue to require appropriate documentation, product-specific evidence. Unscrupulous participants should be pursued aggressively for kickbacks or medically unnecessary treatments, but collectively, we should also preserve a workable pathway for ethical physicians, responsible manufacturers, and most importantly, patients with legitimate medical needs. I respectfully ask that policymakers evaluate the effects of these restrictions on homebound and nursing facility patients, monitor hospitalization, infection, amputation, ambulance use, and total Medicare spending, provide clear safeguards for physicians practicing appropriate medicine, and ensure that reimbursement remains sufficient to support responsible American manufacturing and continued patient access. The measure of healthcare policy should not be how much it reduces spending in one isolated category. It should be whether it protects taxpayers while improving or at least preserving the health, dignity, independence, and quality of life of the people Medicare was created to serve. I thank you for your time and your commitment to America's patients.
Thank you very much. I'm going to call on myself first. It's just we decided that we're not going to stick to this 5-minute rule because we have 3 of us here, so we shouldn't be bound by it. First of all, we have a general question for all participants, whoever wants to weigh in. Many Americans may not be familiar with skin substitute products or wound care reimbursement. Can somebody walk us through how a skin substitute product moves from manufacturer to patient and identify the weaknesses that cause people to profit off this system absurdly? Whoever you want.
I guess I'll go first.
Sure.
The product manufacturing starts when tissue is donated by a mother who just had a baby. Instead of the placenta becoming medical waste, they can donate it to the medical community, to science. In our company, we have our own network that harvests placental tissue. Think of it as almost like any other organ that's being donated. We transport it back to our manufacturing center. It goes through a lot of testing, cleaning, and then a process to put it in the form of an allograft that it's used in the marketplace. Why this went awry? 2 main problems. One, these products require no pre-market clearance by the FDA to enter the market. They're regulated under Section 361 of the PHS, which means as a manufacturer, I kind of self-regulate. I'm subject to FDA inspection, but I can manufacture a product and put it on the marketplace without going through a typical 510K, a BLA, a PMA, any of the regulatory processes, approval processes that we're all familiar with. So that's part of the problem. That allowed these products to proliferate. They started to enter the market at a very fast rate. Again, no heavy spend, no pre-market clearance. Then the second problem was, on the reimbursement side, they were paid for as if they were drugs under this ASP +6 methodology. When I bring the product into the market, once I sell it to a few customers, I've set the price. So folks figured out that they can get a couple of people to pay them a really high price for the product and set it at $2,000, $3,000, $4,000, and $5,000. So now you have a product that you can bring into the market swiftly, and you can set a price, and I'm going to go ahead and give half of that money to the doctor in the form of a discount.
Can I tell you, when you say you set the price, give me an example of what you'd set the price at and what the actual cost to produce it is.
Well, in the old days, you used to do a fair amount of price sensitivity work. At least we did at our company, and we would set the price at an entry point, knowing that there'd be some discounting that eventually brings the product down to a more normalized level from a price perspective. So it sort of settles out after a couple of quarters, frankly, because every quarter we're required to certify what the average selling price is of our products to Medicare. So it sort of settles down. What happened was folks figured, well, heck, I can give half the money to the doctor, and then when I report the ASP to Medicare the following quarter, theoretically, it's less that discount. I'll pull it off the market, and I'll replace it with another one at a high price. Because I can just keep cycling these products on and off the market. That's a big part of it, right? So low barrier to entry, and then you kind of get to set your own price. And people figured out a few years ago that they can start pushing that price higher and higher. And for the life of me, I'm not sure why Medicare approved it. When I met with Medicare a few years ago, I asked them that question: who controls this ASP list? They said, we do. And I said, why on earth are you approving a product for sale at $3,000 when you know it's the same exact product that the same people had on the market 6 months ago at $200 or $300? So for us, it was very frustrating as participants in the marketplace. Now, I know that Medicare had to go through, their rulemaking process and come up with corrective action, but it was painstakingly long for us to work through this issue. I've only been at the company for 3 years, but my company has engaged with them for at least the last 5 or 6 years.
Okay, thank you. Does anyone else want to follow up on that?
Sure, so a couple points I think to remember is that every manufacturer is a little bit different. We don't have our own procurement company, so we actually depend on, and these are companies that potentially could have been organ donation companies that started actually procuring the tissue. So we do buy our tissue, so that's a little bit of a different, I think different manufacturing costs can vary. We actually have the Mass Coalition published several articles that had independent companies, BRG and ATI, provided reports that brought that manufacturing cost average, right? So companies such as mine that we don't have our own procurement, we buy it anywhere between $281 and $500 per square centimeter when it's done domestically, and when you actually have to depend on third parties to do your testing, validations, and tissue procurement. And I echo Mr. Capper that we have been for years going to Medicare, pointing out the flaws in their pricing methodology. We had numerous meetings, numerous phone calls, Zoom calls, and it really just never changed, and it skyrocketed, and companies were coming into the market that really they came in really for the price, and then the physicians started to get incentivized to jump from lower reimbursable product to higher. The product, my personal opinion is that this could have actually been handled several years back when people like Mr. Capper and I were going to them, talking about this. So, I do applaud the current administration that they are paying attention to it. I do think that it could have been done in a little bit more responsible way to not restrict access, but bring it to a level that works for a healthy both manufacturing and patient access.
Okay. Now, just to general understand, I'll skip to the next question. Ms. McDermott, what do people misunderstand about how physician payment incentives work in Medicare?
The Medicare reimbursement system for physicians is pretty complicated, so I think they misunderstand a lot. In this particular instance, I don't think it was well understood in the beginning, the way that the incentives that were just described were driving physician behavior. And I was just going to add on the last question that you and the staff can download the average sales price files and track along as that pricing has increased quarter to quarter. And you can do that by company. So I would just encourage everybody, as you're thinking about next steps, to take a look at that. The other piece that I think has not been well understood is the clinical evidence piece that Mr. Capper spoke to. CMS has repeatedly asked the manufacturers to provide clinical evidence. I believe the last request went out a week or two ago, asking for that supplemental information for future rulemaking. So I think it's really those two things, the ASP plus average sales price plus 6% pricing methodology. The portion of that price that was shared in many instances inappropriately with physicians, the incentives that we saw around, which we spoke out this morning, trips and other kickbacks, and the lack of clinical evidence around these products.
Okay. Next one, and then I want to go to Mr. Sessions. Ms. McDermott again, we've seen bad actors pleading guilty to billions of dollars in fraud. What are they actually spending these stolen money on?
All kinds of things. There are many news stories that share the types of purchases that people have made with fraudulent dollars. I was reading in the New York Times last night, expensive jewelry, boats, trips, even a resort in the Philippines. So lots of spending going on, very inappropriate. We've had reports all over the country of really just bad actors spending this money on additional properties, beach houses, personal spending,
Just unbelievable. to me.
rampant bad behavior. Yep.
Okay. Mr. Alnajar, as a clinician in this space and CEO of an ACO, how would you distinguish between appropriate wound care treatment and practices designed to maximize reimbursement?
Thank you. So, I'm a primary care physician, not a wound care specialist. But that being said, a lot of what we do on the ACO level is we flag trends. We track the Medicare claims data pretty closely. And when we see something going 100x year to year, we know that there's something wrong going on. And the fact that we have close relationships with our doctors and our patients. So the first thing is the way we look at the world is we look at data. We have actuaries that look at data to understand, like, where do we see something that's abnormal? We flag it. Then right away, we connect with our doctors and our patients. And in many cases, as you said earlier, the patients might not have even received the service, or the doctor, their PCP, doesn't think it was appropriately utilized. So that's where we're coming at it from as an ACO, rather than trying to practice medicine and say clinically whether it was appropriate or not. We also ask, a lot of what we do is gather data and information from, the data from physicians, from patients, and we share that with CMS and the appropriate authorities, hoping that it would get resolved. And a lot of times it's very in your face and you could tell it's fraud, but we don't have the ability to stop it as an ACO. We just sort of report and hope the right thing happens.
Okay, thank you. I'm going to go. We're fortunate today. One of our questioners is a doctor himself, Dr. McCormick.
Thank you, Mr. Chair. I appreciate being here today. Appreciate being on this esteemed board, just trying to ask some common sense questions, trying to figure out how we get here and where we go from here. Great testimony so far. One of the things I thought to myself is, how did we get here? Now, everybody's kind of coming from a little bit different perspective. But I'm going to start with Ms. McDermott, since I think you have a vested interest in trying. You already pointed out the abuses of the system, which, by the way, are illegal. So that we already have laws existing. But how did we get here to the point where it was so abused that we had no accountability? Was it a Biden administration problem? Was it a Congress oversight problem? Was it the way? Obviously, we as a government failed to administer this program properly to begin with. Whether it's a good program or not, I'm going to leave that for my next question. But how did we get here where people were able to abuse this for years and have, as you said, Doctor, 100-fold increase in spending with no accountability? How did we get here?
Well, we've talked extensively about the flaw in the payment mechanism. The way that the payment is submitted was broken. I think there's a maybe different layer to your question around the dollars going out of the Medicare program without any oversight. We were talking earlier, if you tried to bill the way that providers billed for skin subs on your credit card or in your Amazon account, you get a fraud alert, right? And somebody would check in with you, and that is simply not occurring in the Medicare program, and it's something that we would like to see more of, particularly for accountable care organizations. We should never be in a place where they are reporting providers for years and not receiving follow-up on those reports and not having those payments at least put on some sort of prepayment review, some sort of check-in to make sure that that's not a bad actor.
Couldn't agree more. And I think it's great that we're getting rid of waste, fraud, and abuse. I think we can all agree that's a bad thing. Matter of fact, I know this industry itself has been hurt because of bad actors, and they want to see it cleaned up also. Do you think we've taken the right steps to catch things outside of this business? Because this business is being focused on probably overly so to the point where we punished even good actors, but do you think across the board, in the way we apply Medicaid, Medicare, and other programs in the government, do you think we've found a way to be accountable, or is this just a one-off that we've found this one industry, we haven't really looked into further? Have we corrected the problem as far as you're concerned from an outsider's perspective and the way the government's administrating its policies?
I'll say we strongly support the government's action on skin substitute payment, but to your broader question, no, we still think that there needs to be more done to get in front of these problems. So we don't want to be cleaning up $14 billion on the back end. We want systems that move faster. We think there's a lot of potential with new technologies to move faster on fraudulent actors. But really, the way that accountable care organizations recognize the patterns in the data should enable Medicare and Medicaid to move on those patterns more quickly so that we're catching things a couple months in, not 4 years in, 6 years in.
I agree. Now that we addressed that we all hate fraud and we all hate bad actors, let's address where we go from here, because unfortunately, as an ER doctor, I saw tons of chronic care issues worth healing. We know we have a progressive stage treatment plan where if one type of treatment doesn't work, we go to the next and to the next. This happens with medications as well as skin substitutes in this case. What I've seen is the upper level treatment when you can't heal normal ways. We go to all the way to this amazing technology of taking something which is basically God's gift to babies and concentrating healing factors along with maybe a hyperbolic chamber, which gives you even the next level. And yes, it's expensive, but once you heal, and it's transformative. You can literally save a limb. You could, and by the way, you start having multiple limbs chopped off, your chance of dying increased dramatically. And of course, it doesn't cost any money to treat somebody who's dead, but that's not what we want, is it? So I think we could all agree that there's some way, there needs to be a way to keep this industry alive. And unfortunately right now, it's my opinion, and I would ask your opinion, this price point that we've arbitrarily set, which is anywhere from $106 to $156, the median being about $123 roughly dollars, is not enough to keep the industry alive. Now, I've talked to the administration, and unfortunately the response was, yeah, we've cut back 99%. Well, that means you've destroyed the industry. We have it in my district. We have industry that basically 70% of their employees are laid off now. And let's go to the next level. What happens when you can't administer that to people who can't heal now? When you have that chronic care issue and you don't have a solution? That's not a solution. So when we do talk, I know, Mr. Capper, you talked about that price point, and we didn't want to get too much into specifics, but would you at least agree that the arbitrary set point of pricing right now is nowhere close to keeping anybody in business, and essentially we're putting everybody out of business?
Yeah, I think the price point is important, and I do think it's low. Aside from the price point, though, the way products are paid for is just as important. What do I mean by that? If I sell you the product and give you a 40% discount, I'm giving you an incentive to utilize and overutilize the product.
It kind of sounds like a PBM to me.
Yeah. Yeah, it does.
Sorry, not to become political or anything like that,
Yeah.
but this is the problem. We don't have
It'll take us
fair,
a whole-
transparent applications of pricing.
Yeah.
We have incentives that are warped, right? We don't encourage people to use the standard application of healthcare. In other words, I try this first, if it doesn't work, this next, and then this next. That's the progressive way that all physicians are supposed to apply any sort of treatment. When you come in and you're having trouble breathing, I'll just intubate you, right? I go through a step-by-step, high-flow nasal cannula, a non-rebreather. And then if you can't breathe and I can't get your oxygen level, I have last resort, I'm gonna do this. That's kind of what we're doing in this industry too, right? And Ms. Olmsted, you actually pointed out a really good progression. You talked about the balance in healthcare. You talked about how, look, we don't want to have fraudulent, we've had bad actors, we've of course done things to eliminate that. It's always been illegal, but would you agree that out of all the waste, fraud, and abuse that we've found, about 2/3 of that comes down to about 100 providers, a very small number. So in other words, we're punishing an entire industry because of a few bad actors, and it's destroying something that's very good for the overall populace.
Yes, and I'm so happy that you're here, because I think sometimes it's difficult for someone like myself that has worked in healthcare my entire career to try to convince somebody of things that they haven't seen firsthand. When you see it firsthand, it is so impactful that for the rest of your life, you carry that with you. And every decision that you make beyond that really is impacted by everything you've seen previously. So I've worked over the last 7 months tirelessly with Congressman Sessions and his teams in having these discussions and discussing if there's just really common sense things. If a treatment doesn't work, and there's data out there, some will say it's 3 treatments, some will say it's 6, and let's just say it's somewhere in between, and we all can agree, if something doesn't work within a month, you discontinue it, right? I mean, you said it yourself.
And no patient is the same.
Correct, and this is something that we have proposed. I think USA manufacturing is so crucial. This is something that I can't echo enough, because this isn't a ibuprofen. This is a biologic that is derived from human tissue. That means that we discard tissue all the time because the mom may have HPV, some pre-existing conditions that we don't really know what it does. There's not enough data out there. So we would rather be safe than sorry, and we discard it. When we bring product in from India, and I think earlier today we discussed this, and we have no idea where it came from. There's no regulatory around it. Mom goes to a hospital, there is no medical history, there is no waiver. That tissue is just thrown in a bin, maybe sterilized, we don't really know, dried, and then put on a ship.
And to make a comparison, by the way, this is the same problem we have with medications produced overseas also. We have inspections in the United States where you can just drop in on a moment's notice, open your doors, I'm gonna examine everything, but if you go over to China, I have to give them a heads up of weeks. And I show up, they have time to clean it up. They could be subsidized by the government. It could be different packaging, different content. So they get time to literally, we don't have testing for medications coming to the United States. This is why Made in USA actually matters. This is why by the way, we have plenty of product here, plenty. And the fact that the biggest abuses have been from overseas as well is very concerning. But I think if we were to sum up, and I think we could all agree on this, there's been a massive amount of fraud. Most of it was based on a few bad actors, both here as physicians and those overseas. Outside of that, we have a very important industry that should be used appropriately and priced appropriately so we can have that as something that treats and provides something as a best case scenario for those who need it most. Could we all agree on that? Does anybody disagree? With that, I yield.
Thank the gentleman. Let me be quite honest, Dr. McCormick. When I saw you in the men's gym yesterday, I viewed that some of the conversation, very appropriate, we were working out. I'm advised I need to do that at my age, and I would advise you at your age you should do that.
I try.
But we had a discussion, and I told you how valuable I thought you were to this organization, not only as a former member of the United States military. You told me about landing helicopters on aircraft carriers, that was stressful, but that being a member is perhaps more stressful for you. And so it was really a friendly conversation. Little did I know that you were up on this conversation. So I'm going to take my couple minutes. We're going well over time. The distinguished chairman allowed that. I think one of the most important things, because members also have opinions, is that if you're going to charge for this, you should have to have been through training and certified to do it. One of the more interesting parts that I learned a couple of years ago was about ALS, and a guy I went to high school with is one of the leading ALS physicians in the country, Dr. Peter Grant from Oregon. And Dr. Grant said, Pete, did you know that people can just test for all sorts of things even though they are not trained, and it costs easily $100 million a year for tests that are paid for by CMS, that then they have to refer someone when they couldn't even read the test. So CMS is paying twice.
Insane.
So it seems like to me, and I know we'll get to each of you, it seems that CMS has well within its grasp, its reach, its ability, the desire, and I think that within their grasp to say, if you're going to charge for something, you have to be trained on that. You have to be able to be certified in that, and that has to be part of your component. I think something else would be if it's a de minimis part of your regular activities, it just might be something that you charge just because you're on site, as opposed to that's what you came for. Oh, I happened to see this. Oh, I happened to just notice this, so let me do that, as opposed to the reason why a patient had called them there. So I think that there are a number of things that I would encourage out of this hearing. The gentleman, Mr. Grothman, and I, as well as you as a member of this subcommittee, will be able to provide our official feedback. We've held a hearing. We've done the things which are important, but should say to CMS, we believe you should accept some reasonable things. Now, the other things that I've heard that are equally as reasonable, Ms. McDermott, Mr. Capper, Ms. Olmsted, for sure Dr. Allenar, and that is that they really could catch the outer liars. So a little bit more about the story. My story, I'm the subcommittee chairman for government operations. We have the main content to looking at the $2 trillion worth of what's commonly called waste, fraud, and abuse. I call it misdirected payments. And we found out that essentially the same thing happened here that happened as part of the $2 trillion. The Biden administration didn't go to work. They let computers do the things that employees would normally do, and that is there was no review of billing as it came in. And so it was an open way for people who would commit fraud. And so I have met with CMS. By the way, our new CMS director is a very with it young man. He's a physician. And Dr. Oz takes very seriously the ideas which we present to him and he presents to us. But essentially, they do know who the bad actors are. They can see them, and the dramatic rise in spending should drive them directly to it is. Now, I'm going to ask some questions. I don't know who's a provider. Ms. Olmsted, you're a provider today. I'm sorry, you provide services that CMS. So I'm going to probably ask the question, is CMS aiming at those people that did the wrong thing? How are they determining what the marketplace is? But my point is that I think that CMS is it my conclusion? Yes, I think it's pretty close. Do I need to hear it here today? I've heard it from you and other people. If they provide services below the actual ability that people have to provide that service, we are arbitrarily denying people that need this. Probably a lot of people in the 17th District of Texas, a heavy rural district, they're not being provided the services that they need, and it moves itself to people being in the hospital, people having to go from their home to the hospital, perhaps from a nursing center, take an ambulance, go to a hospital, have to go through some things that are very difficult for the family and hard on the body, CISPAS, and maybe losing arms and legs. So I think what I would say to you is I heard you say, balance, balance, balance. Let a medical professional, in this case I would say it might be a nurse, maybe a nurse practitioner, maybe someone, if they're trained in these subjects, we should trust them. Should there be parameters? Yes, there should be parameters. Should there be some caps, some ways to evaluate it? Yes. But in my opinion, no one at CMS should be surprised more than a month after a bill has come out if they put the appropriate parameters in place in their computer system. I'm sure they'd argue, well, the computer system, Congress didn't pay for it properly, so Congress is at fault. Is at fault, not us. Okay, well, I'm willing to accept part of the feedback. My point would be to you, Dr. McCormick, is that I have received feedback, unaided, like you gave, that said we really need balance as much as we need anything. And I want to thank you for the conversation we had last night, but I want to thank you for being on this panel and for the time you gave. Okay, now I'll yield myself such time as I may consume that I've had a chance to dialogue with my colleague here who is, I know, got other things to do. Ms. McDermott, I found your conversation very instructive, and you pointed up the dramatic rise in spending, the dramatic, what I think, pointing to directly to fraud and people who were taking advantages of services, up to and including people who spent maybe $1 million only to then pass away. Seemingly, to me, the product works if it's applied properly, if it does these things. So I don't ask that you go back. It was just an example you gave, but I would ask as a question, would your professional insight tell you that person probably did not die of not having enough proper wound care paid attention to, and it was probably something else? Because this is an exorbitant amount of money. Do you have any insight into that, ma'am?
I think you're right. They did not die from just wound care, but in these instances, they were receiving wound care in their home and no other services. So someone was in their home, nurse, in one case, an urgent care physician was in their home applying just enormous amounts of skin substitutes without any other regard to their care. And ultimately, I think that's likely what killed them.
And you and I are guessing at that.
Yep.
And I would assume I'm going to accept what you've said because I believe it's true. It seems like to me that someone should be held liable for that because they allowed something like that to have to happen. It would be the use of so much would say that there was a real problem with the administration. Oh, maybe that was just fraud. Maybe they knew that CMS was not at work and turned a blind eye to it. I think that your instructive nature is important, that numbers do matter. Numbers do tell a story. Numbers can be seen, and individuals should be held accountable. I'm not sure you ran through your ideas about catching this and prosecuting it, but I will tell you that your use of these numbers to show how out of balance they are is very important. And I would hope, perhaps I'll let you say it, but that's part of the story, not the whole story, and that we need to still have this product, and they're trying to kill it.
We have shared information about clinicians who billed over $80 million on skin subs in the first half of 2025. We've shared names and information with CMS. So, and accountable care organizations have been doing that for years. I think that one thing that I would offer to this conversation is the Medicare Advantage experience. So your colleague, Dr. McCormick, was talking about sort of the step in terms of treatment. What we see in Medicare Advantage, which again is about a little over half of the seniors in Medicare, is almost no utilization of skin substitutes because they are working through those utilization steps. So there is use, and it is appropriate, and I agree with you that I think there are instances where it is appropriate, but we do not see this runaway train in Medicare Advantage, nor do we see a record of the types of horrific outcomes that have been discussed today in terms of hospitalizations, amputations. I mean, I certainly have not seen evidence from Medicare Advantage of that. If that evidence exists, we would love to see it. But I think that there is some instruction from that half of the Medicare program where we don't see these types of abuses.
Yes, ma'am. How might you see it?
the evidence of bad health outcomes from the Medicare Advantage population.
Well, I didn't say Medicare Advantage.
Oh, yeah.
You said that. I'm saying, how would you see that as to draw some evaluation? Congressman Sessions, we know that what happened is the rules changed, the amount of reimbursement changed, and as a result of that, your testimony today is, and you have not seen anything, any outcome that might be negative. How would you see that?
Well, in traditional Medicare, I think you're right. I think what you're getting at is that we would have to wait to see claims. In Medicare Advantage, what I'm saying is that we have not seen the utilization or spending that we've seen in traditional Medicare. And if the consequence of that, no utilization of skin subs, is really bad hospitalizations and other bad health outcomes, I assume we would have evidence from the folks at the manufacturers at this table about those bad health outcomes and Mass Coalition and others.
Good.
We've asked them for that.
Okay, good. And I appreciate that, because this is the kind of testimony that needs to be before this important subcommittee of which I serve on, and I'm proud to do so. Doctor, you have indicated that you do not necessarily go and treat all of these, but you're aware of, you run around physicians. We heard Dr. McCormick. I've heard Dr. Marshall, who is a United States Senator. I've heard Dr. Bill Cassidy, who back in February and March, when we had breaks, they told me, I did not ask them because I don't know their schedule, that they believed that they were hearing from their colleagues about a fear or about the prominence of people not being properly taken care of wound care-wise that would turn into something else. Do you have testimony today that could provide any insight into that question?
So, as I said earlier, I'm not necessarily a wound care expert, and, from my understanding, being around physicians and others, there is definitely a clinical use for wound care. The question is, as we saw on the chart, was there some abuses that happened in the last several years because of pricing strategies and the way that providers make money? Yes, that's also clear. We saw that as well. And our view is, rather than trying to dictate, what should be done clinically or not done clinically, what we think, my personal position is, I don't think providers should be making a lot of money based off what they use, because ultimately, let's be honest, anyone making money off using a certain product will be influenced one way or the other. And the other thing is to have mechanisms in place, because right now we're talking about skin subs. Next year it could be a brand new topic that's an unknown to us that we don't even know exists that will hit our books next year. And what we need are groups like accountable care organizations that are looking at the data, talking most important. The data's not enough by itself. You have to also be talking to the physicians and the patients, boots on the ground, to really understand and flag it. And my personal opinion is, with this prepayment sort of review, is if we're flagging something and it looks like looks like a duck, quacks like a duck, just hold off the payment. Let's do an investigation, and if everything's fine, pay it, great. But if not, because one of the challenges that I think we've seen here is a lot of this was sort of what you said earlier. It's the pay and chase method, where they make all these payments, maybe automated automatically with computer systems, and then now it's like, let's go track them down, and it's hard getting your money back when it's a resort in the Philippines. So,
Well, okay, let's suppose I know a little bit about Medicare after 28 years as a member of Congress. That is, Medicare pays when they get the bill.
yeah.
Medicare does not have a model that they're very good at, and which is why the level of about 18% of Medicare is fraud. We knew that starting this morning before I got up. Now, it rose substantially when people don't go to work, and you know that, and that the proof is in the pudding, as Ms. McDermott has well substantiated. I would just say to you that these are reasons why we have these hearings. It's my hope that CMS, of which I have known for many years, has very bright people, and they have a hard job. But I think that for a rulemaking organization that sees firsthand the fraud, they should perhaps want to be more nimble at spotting the fraud, using AI if necessary. So it's my hope they'll be listening to this. Our great young administrator, Dr. Oz, I know cares very deeply about this, because if money is spent somewhere rather than the right purpose, it will not only encourage more fraud, it will not go to the people who need it. Mr. Caper, thank you for being here today. I found also, once again, your data and information and your positioning very important to us. We now have had a little bit more of a conversation about an agreement. Fraud is bad. Like Dr. McCormick said, nobody's for fraud. But the real question is, how do you balance the needs of the nation and the taxpayer with the needs of an 80-year-old person who is an American citizen and probably is someone's grandfather or grandmother who literally at the end of their life is in either a rural area or perhaps a nursing home and needs the services in the circumstances where they are, as opposed to running back and forth to the hospital. It may be the family circumstances. It may be their own personal circumstances. Wound care is a certified positive attribute, I think, in healthcare. I think it's known. I think it's understood. What would you say, now that you've heard the pluses and minuses of this, what is your take on where we are presently with the rules at CMS and the outcomes that they are presently working with, and then the things that we have provided as perhaps feedback? What would you add or subtract or think about this in an evaluation, sir?
Yeah, I think it is clear to us who are participating in the industry that the problem got too far down the road. We could look at that chart and scratch our heads and say, well, gee, when it doubled from year to year, why wasn't somebody pulling a lever to stop this bleeding?
Well, they didn't go to work.
Yeah, that's probably what it was at the time. But then it got completely out of control. And what's happened is a classic overreaction where denials are way up, audits and clawbacks are way up. People who are really good providers of service are afraid to use the product, and patients are going to suffer. And in the rural areas that you mentioned, where folks have a harder time getting to a healthcare center, it's going to be worse. And you're going to see hospitalizations increase, and eventually you're going to see amputations increase. And you can look at the data that someone with a lower extremity amputation has a 5-year mortality rate of about 50%, which is similar to the worst cancers on the planet. So it's something that needs to be addressed. And I think you heard some good recommendations from the panel on what CMS can do to course correct, because clearly we overcorrected. I think we all agree with that. Some of it's price, some of it's some of the other parameters around the way the program is being administered. Longer term, the word you used was perfect. They got to be more nimble. They got to have the ability to see this and react. The only time I ever want to see a chart like that is if it's my revenue for my company. When it's, as a taxpayer, when I look at that, I'm like, oh my Lord, how can that happen? So, and I know it's easy for me to sit here and say that. They have to work within certain parameters and rulemaking, et cetera, but they got to have an easier pathway to course correct and be nimble. Because unfortunately, they do pay and then chase.
Thank you. Ms. Olmsted, you're the last witness left that I have not engaged yet. Thank you so much for being here today. I will tell you, until last week, well, we were off last week, 2 weeks ago, I did not know about this hearing, and I think that the chairman having this hearing does come on the heels of the administration forthrightly saying, hey, Congress, we think you should care about this issue also. We're going to tackle it pretty much on our own, but we would like for you to become a partner with us. And that is the perspective that I take. I'd like to be a partner with CMS. I'd like to be a partner with Dr. Oz. I'd like to have a way to sit down and make them know that we do understand. And I think we understand it a little bit slightly differently because we go home and hear feedback and we hear from people and we do know about the things that Dr. McCormick or Dr. Anajara has spoken about, their real lives. But what I would say to you is that probably as a result of this, I would anticipate that we will have the great Dr. Oz, who will have a chance to come up and he will be asked questions like, did you know we held a hearing on this? Did you know that we are trying to follow up and look at the same issues that perhaps our young vice president is looking at, that we have looked at and analyzed, not just me, Chairman Sessions, about how $2 trillion worth of over missed payments or payments that were wrong happened, and they're tackling that. Well, Glenn Grothman, as chairman, is tackling this same issue. And please come up and engage us because that chart right there is obnoxious. And I can tell Mr. Grothman, he probably, as a result of what Dr. Oz is doing, has done, is probably not gonna, that won't be next year. We will not see that for this year. But what we should also keep in mind is, but the corresponding balance should be, we want to make sure that we didn't kill the process that people really need, and medical doctors need things to be able to help patients too. We are arbitrarily, in my opinion, stopping things that could help physicians to help others. All right, Ms. Olmsted, you've heard my opinion all day now. I'm really interested in your opinion because you're having to deal with putting, I assume you're involved somewhat, could be called home health care. You're out in people's homes, you're at nursing homes, you're in people's homes, you're helping grandparents, you're helping people that may be by themselves, you're helping veterans, you're helping people that I want and would expect you to help, and yet you're perhaps impacted by your ability based upon being paid back to run your business, to have the proper person do this. Please tell me about your ideas about the current processes, payments, and what you think.
Sure. So I said this, and I'm gonna say it again, is that being here is truly a privilege because we're speaking for the people who can't be here to speak for themselves. And I think that that's something that is extremely important to me, that we brought our own stories. And I appreciate everyone on this panel because even though we work in different fields and we perhaps treat different patients, I think it's really great to hear that no one thinks that fraud is good. No one is ever going to be complicit, at least here. So there are many people like us that want to do the right thing. I think what keeps me up at night is exactly what you said, is restricting payment for physicians that really do go out. And just to paint a picture, when you have a rural area, and I know you know this very well, if a single physician sits in a hospital setting or a clinic, 50 patients can walk through their door at any given day. If you're a physician that takes that great responsibility to leave your office, get on the road, get in a car, and drive hours upon hours to maybe only be able to see 3 patients, you're restricted to a level that is just not sustainable for your practice. So I think it's extremely important for us to look at every place of care, not just certain places of care. And I think here, what CMS did they followed the methodology, the pricing methodology that is meant for hospital settings and not settings that we service more, which is the rural areas, home health and nursing homes. And one of the things that I very strongly support is certifications and really having those physicians understand wounds better. And one of the things that Ms. McDermott testified is that exact scenario where a physician went into a home, they didn't do the proper testing, and we can assume it's fraud. We can also assume that it's lack of knowledge, that they put themselves in a situation to treat someone that they may not have known what was appropriate for that treatment or not. So I think, you know, having enough, having a proper reimbursement rate for us to be able to educate doctors, for us to be able to educate clinicians and everyone, manufacturers and everybody involved in this it has to happen.
Thank you for waiting for me. I appreciate it. First question, this is for anybody who wants to jump in. Should CMS have greater authority to suspend payments when it identifies rapidly emerging billing anomalies? And do you think they would have used it if they could have, something's going on here, slam on the brakes, these people got to wait a month?
Well, my understanding is they sort of do have that. If they have questions about how a provider is billing, they can automatically put that provider on prepayment review. And then every claim has to be reviewed in advance of being paid if they see bad behavior. So the process is kind of there. Maybe it needs to be beefed up or tightened up a little bit.
It didn't work in this case, right? Why didn't it work? If they had the ability, you look at these numbers, they're just shocking. Why didn't CMS slam on the brakes?
You know, I'm not sure exactly why they didn't slam on the brakes earlier, but to your point, they do have this process. They have MACs in place, you know, UPICs, these different sort of entities that make these payments, and they're able to do prepayment review. You know, our suggestion is, you know, ACOs that are closer to it, that are seeing the data, that are engaging with the providers and the patients, they should have a direct line to that process that's already in place, that already exists, to beef it up where we can put a brake on it. And that is what I think is a good sort of solution, because folks like Vitalize and others that represent more than half the Medicare beneficiaries across the country, we're on the hook from a quality perspective and a financial perspective. So we were sort of ringing the alarm bells, but you know, the current processes weren't always integrated, and you know, and so what we're proposing is sort of what you said, like a beefing up of the existing process where they're able to take our insight and put a freeze and then pay it if it's appropriate, or deny it later on, rather than paying and hoping to get it back.
Why didn't they this time, though?
I'm not sure.
Just a get along, go along attitude, or?
I think the MACs were very frustrated with this, the ones that I interacted with pretty early on. The challenge is if a provider submits a clean claim and it checks all the boxes, they're going to pay it. And again, one of the issues here was the structure was out of whack. You could bring products to market at a rapid rate. CMS was issuing new Q codes for these products at a very rapid rate. We went from probably a couple dozen products to a couple hundred products over the course of a few years. The pricing is set by CMS, so I'm a provider. I check all the blocks. I used the product in the right way. I just use a very high-priced product. They paid the claim. Now, we've heard stories about people who overutilize the product and used it for the wrong patient at the wrong time, et cetera. And there are people that probably submitted claims that weren't necessarily clean claims, and they probably weren't, in some cases, fraudulent claims. But part of the challenge is the structure of the system was set up that people could do this and submit clean claims.
Okay. Were there market participants that had incentives to ignore signs of overutilization because it benefited them as well?
Yes, I think a lot of the fee-for-service reimbursement system was incentivized to not care about this at all. The reason the accountable care organizations care about it is because they are financially responsible for $14 billion growth in spend, whether those are their providers or not in traditional Medicare. But if you're not in a system like that that's accountable, we've all been there, right? This doctor's doing this thing to you, this doctor's doing this thing to you, this person's doing wound care. Nobody's talking to each other. And as other panelists have testified, a lot of this was happening in homes, in skilled nursing facilities, in nursing homes where there was no oversight of the patient. So I think there are lots of incentives for people to either look the other way or just not say anything. The one other thing I would add is that we saw in our membership a large number of providers holding claims. So those claims would hit much later in the year. The service maybe was in January, the claims were hitting in September, surprising the ACOs and creating lots of havoc in the billing systems. And so I do want to just say, in CMS's defense, I think in the aftermath of this lesson learned, they have taken a lot of steps to speed up the communication from the accountable care organizations to the MACs and to the fraud units in an attempt to get in front of this more in the future. It is unfortunate that this happened, of course, but I do think there has been some action to try to rectify it.
I think it's very important to also highlight the good actors, people that chose not to partake in that, and there's thousands of providers that could have taken advantage that didn't. And I think that it's also important to note that CMS did have the guidelines, they're available for them, and the audits, generally people that did commit fraud, they did not have clean notes, they didn't have clean claims, and have they used their authority to act swifter, that number wouldn't be 14.4 billion.
I guess nobody likes to be a snitch. Did everybody kind of know this was going on for a couple of years though before it?
I actually think that a lot of people did quote unquote snitch. We brought many instances. We had a policy internally that we didn't allow any of our providers to treat hospice patients. That was just zero tolerance policy. So we had physicians that would argue with us, and if we felt that they were doing anything wrong, we did have different individuals that would report them, but we never saw any outcomes on that.
The ACOs also did snitch. They reported to CMS through the channels. Unfortunately, at the time, and you may want to speak to this, the channel to do it was a CMS.gov inbox, right? So you're sending an email to an inbox, waiting for a response, waiting for action. I think that as this problem became more acute and more visible, those reporting systems have been massively improved. So now we're talking to actual humans in Kim Brandt's office and able to get attention on it more quickly. But in the beginning, the telling process was very slow.
Follow-up question along those lines, and this is only because the people back home always wonder, maybe you guys know, maybe you don't. Was a substantial sum of this money recovered, or was it all gone on trips and jewelry and who knows what?
I don't know that we have that data fully, but I do know that people who were held accountable, assets were seized. What that's worth, I don't have the ability to know.
I don't mean to be partisan here. Is the new administration, you think, a little bit more on the ball on this? I mean, a little bit more to follow up and let's do something about this when reports are made and that sort of thing. I don't mean that to be partisan. I just find in general they're a little bit more across the board, hit the ground running.
I think it's been a huge priority for this administration. In particular, skin substitutes, but other forms of fraud have been a huge priority. We've seen, I think paired with their health technology ecosystem and the work that they're doing on AI and technology, all of those things come together for just a different type of action and more quickly.
Who made the most money on this? I mean, if we have an example or a subgroup, who was making the money? Or was everybody making the money?
We have some data on that. I'd be happy to share as follow-up in a chart form. I don't have it top of mind.
Okay. Mr. Al-Najjar, Your organization's in a unique position to survey utilization patterns across multiple health systems. I want to talk to you later, because isn't there wide variety in utilization across the board on a wide variety of things?
Yeah, I would love to talk, and there is a lot of, and I really do believe that we sit in a unique position by integrated with the physicians, the patients, and having the data, and most importantly, being accountable. Ultimately, people tend to notice these things when they're on the hook for it.
Which warning signs should regulators and law enforcement look for when identifying abuse?
Which warning signs? I'll tell you what we do, and, we look at abnormalities from the norm, and then we investigate by talking to the providers and the patients. So it's very unnatural in healthcare for things to go 10, 15x in a year, 2 years. And when we see that, we investigate. It doesn't necessarily mean it's wrong, but then we investigate. And then ultimately, I think that's one of the challenges that CMS has. It's challenging for them to get on the phone with all these doctors and patients to really understand what's happening on the claims, that ACOs can serve that function to really, and get the notes and get all these things to really paint a picture around the numbers.
One more thing. How do you distinguish between appropriate wound care treatment and practices designed to maximize reimbursement?
For me, as I said earlier, I'm not a wound care expert, so I'm not going to talk about the clinical ramifications, in terms of what's appropriate, what's not. But in a lot of cases, it was clearly, we've seen cases where the patient never received the care. We've seen patients who are on their hospice, and hospice patients should not be getting this type of care. We've seen, just extreme examples that, anyone could tell you it's wrong. The nuance of, whether it's clinically appropriate or not, it's not really our position to play.
Okay. We've obviously focused on skin substitutes today. One of you, I think you touched on catheters. Is there anything else that any areas that you think are ripe for cheating?
Absolutely. So urinary catheters, they were a 24 thing. They resurfaced again in 25. You had obviously the skin subs. We're also looking at, some genetic testing, glucose monitoring. And unfortunately, and this is the part that's, you're not going to like the answer, is there's a known unknowns. Like right now, there may be something that none of us are thinking about in this room that might be the big thing in 2028. And I think the most important thing, as technologies progress, as tools progress, I think the most important thing is for people to be connected. And I think ACOs could serve as that, looking at the data, looking at provider, and connected closely. I think payment review is a key thing. If you could stop the dollars going out when there's something fishy, you're going to stop a lot of the fraud versus having to try to claw it back years later.
Well, okay. I'd like to thank you for being here. It was certainly an eye-opener to me. I think we have a little bit of a moral breakdown in America overall, because it seems like this is the session of hearings on people stealing huge amounts of money they don't deserve. And the question is, why is all well-educated, well-paid people in their own right just going nuts and stealing billions of dollars? But I appreciate you being here. I'll appreciate if you hang around for a second afterwards, and we'll talk to you a little bit more. Like I said, we had a partisan thing here today, and none of our Democrats showed up, which is too bad. I will rub it in tomorrow and tell them how much they missed. I'd like to appreciate Dr. McCormick and Mr. Sessions for being here. And I had 2 other hearings that I had to vote on, which is why I had to leave the room for a second. But I really appreciate it, and we'll see what we can do to publicize it. Obviously, we have a crisis in this, in addition to the fact that stealing is no good. We have a crisis in this country as far as cost of medical care. And insofar as this is part of the reason for the cost, it's important we disseminate to the public. And insofar as both parties are looking for a solution, we hope that solution goes through you. So I'll try to make sure before I vote on it, it goes through you. But thank you for being here, and I guess that's the end of this, and I'll run up and chit-chat with you for a second. So again, thank you for coming all the way to our humble hearing room.